Hello. Welcome to our 24th live stream at Jemsek Specialty Clinic. I wanted to start today just with a disclaimer. We are going to be discussing concepts of sleep and sleep disruption, but obviously every person and patient is different. So if you're having sleep issues yourself, you need to contact and work with your local provider to get help and prescriptions if needed. Having this conversation about sleep today, Dr. Jemsek and I did a lot of prep work and realized that there is a lot to talk about as it pertains to sleep. So this will likely be two different live streams about sleep. But let's get started. We wanted to start the conversation touching on some general concepts of sleep and why it's so important. So Dr. Jemsek's going to talk about that a little bit before we get into our questions.
Thank you, Rachel. Good morning, everyone. It's been several months, and we do apologize, but our clinic moved, and there have been some other changes, but we're back, and pleased to say that we've done 24 of these one-hour sessions in roughly 30 months or thereabouts. So we'll try to get back in rhythm and probably do another session on sleep in the next few weeks before the end of the summer. So why is sleep important? Is any of you who follow JSC appreciate we have an acronym that I created many years ago. It's called POEMS, P-O-E-M-S, and the S stands for sleep. And early on I tried to identify what physical outliers were detrimental to immunologic recovery other than the obvious failure to bring effective therapy against pathogens. And sleep has always been extremely important. We have to check our own boxes, and patients understand that. Some patients are a little disappointed that they can't start right away. But if we don't have our affairs in order and some stability restored to the immune ecologic status, if you will, then we're doomed to failure, and nobody wants to fail. We want to make this a very productive and positive experience to the extent possible. And so sleep is extraordinarily important. Before I get too technical with the aspects of sleep, I want you to know that it's a broad subject. It will take 2 hours, most likely. We're not going to get into specific dosing of certain psychotropics, but we can talk in generalities. And I'll turn it over to Rachel.
So yeah, we'll kind of jump back and forth about the importance of the different phases of sleep and things that can disrupt sleep, but the questions I think will guide us with some of those as well. So we'll start with our first question that came in asking why sleep is so important during treatment and why Lyme affects sleep. Dr. Jemsek?
Well, to just give as direct response as possible, our brain is a metabolic organ, just like all our other organs. It produces waste, quinolytic acid, hyaluronic acid. And these are just a normal byproduct of metabolism. That metabolism, I think we have to assume, is heightened if the brain's inflamed, which is sine qua non for Lyme encephalopathy. The brain is inflamed. It has its own immune system. It's creating waste. That waste has to be disposed with because left alone, it's going to be or have deleterious effects on the residual neurons, which are already under attack. So our brain does not have a limbic system. So we don't have lymphatic drainage except for a small area in the vertex top of the brain that's just not adequate. And I think that I'm going to put you on to TED's talks if you're interested in this further. And some of these investigators have published and lectured about the fact that during the evening with deep sleep, and we'll talk about the phases of sleep, deep sleep is delta sleep. That is where the brain is entirely quiet. What happens is we get dilatation of the vascular channels and the meningeal channels, and they intermingle. And that process through venous access and riddance clears those toxins, and to some extent, sometimes better than others. Now, if we don't have that sort of thing going on, anybody that's gone through 2 or 3 sleepless nights knows that the brain is not working so well because the toxins are being carried over into the next day. And I think that's the simplest concept that I can provide just to get us started.
Yeah, and just to touch on that too, I mean, Lyme has such a big effect on sleep, like Dr. Jemsek said, because of the different disorders of sleep that we'll get into a little bit later as well. Another question that we got that was a good one, asking how many hours of sleep does someone during treatment really need? They're stating that this is an IV patient and there are times when they sleep too much or sleep very little. It's very inconsistent. So this was an interesting question to us because sleep is very dependent on the individual. There are some patients that we have that get just 4 hours of sleep, but it's really deep sleep, and that may be all they need. Whereas other patients that are in the height of their treatment and have a lot of inflammation going on sleep up to 18 hours a day, and that's what they need. So the sleep is going to actually be inconsistent and fluctuate through treatment, and that's okay. One thing that's really important is, support in a patient's life. So, if a patient is living back with mom and dad or a partner or spouse, knowing that there are times in their treatment where they might not be able to sleep very well at night, but that might mean that they need to sleep 8 hours during the day. And that's okay because that's part of helping their body to reduce inflammation and be able to take on the treatment that's coming their way. Anything to add to that?
Well, yeah, just in other words, our goal is just to make sure that a patient is getting quality sleep at some point. Try to promote delta sleep at some point during the 24-hour sleep cycle or 36-hour sleep cycle, whatever it may be. And that's what really matters. And whether they sleep 10 hours or 16 hours doesn't matter. Sleeping 16 hours versus 6 or 8 hours sometimes doesn't mean better sleep. It just means you're in the bed longer. It's about the quality of sleep. Now, we have on top of that weakness and physical inanition or inability to function. That goes into it as well. But as we get into this a little longer, we'll talk about some of the things that are reversible or approachable in terms to try to achieve a more normal and restorative night of sleep.
And that kind of ties into our next question. Somebody wrote in asking why we sometimes ask for sleep studies. So the feared sleep study and sleep apnea diagnosis. So a lot of times we will ask similar questions at our visits. Most of my patients are used to getting the same question over and over as it pertains to sleep, and that includes things like, are you falling asleep adequately? Are you staying asleep? Are you dreaming? Are you in pain? How many hours of sleep are you getting? Are you then waking up refreshed or still sleepy? The other questions I ask are, do you know if your partner has ever complained of you snoring or gasping or choking? Some of those things can indicate possible types of apnea that we do see with Lyme patients and just with humans in general. But apnea can affect patients' oxygenation status during sleep, which causes poor quality of sleep. So the big things that we look for, if we've ruled a lot of other things out, is to then ask to get a sleep study so that we can get rid of other things that might inhibit quality sleep. When we look at a sleep study in the Lyme population, it's important to look just not for obstructive sleep apnea, which is, an obstruction from an enlarged tongue, thicker neck, overweight, things like that, sinus congestion, but also central sleep apnea, which we see many more times in our patient population. The reason it's important to distinguish between the two of these is that they require different types of treatment. So a lot of people are familiar with, a CPAP device for obstructive sleep apnea, whereas a central sleep apnea might require a device called a BiPAP. So that is definitely an important test to get done if it's needed for that patient. The next question that we have is asking about, does having a habit of going to bed at a certain time help with good sleep? The answer is yes. So we talk about sleep hygiene and the ABCs of sleep a lot here, just because sleep is so important as one of the mainstays of stabilization. So having a certain time that you go to sleep helps with setting your circadian rhythm. It helps to trigger your brain to start to get sleepy and ready for bed. Sleep hygiene doesn't include just taking your sleep medications. It includes, eradicating stimuli that's going to excite or wake you too much, right? So we always tell people, no screens or limited screens. As Dr. Jemsek was saying earlier, no scary movies or thrillers right before you hop in bed, no exercise right before bed, being in a dark, cool environment where you sleep, and having kind of these same habitual routines for sleep will put you in the best possible place to sleep well through the night. Anything to add to that, Dr. J?
No, you did a great job, but just to reiterate, we try to break down even more simply in that, do you have trouble getting off to sleep? Is that the main issue, or do you have trouble staying asleep, or is it both? And that's a survey we take each and every patient, and many times, many visits. So how's the sleep going? Because the disease and our therapy can influence sleep patterns, and we don't want to disrupt the patterns to the point that it becomes counterproductive and has to be restored. So at some point soon we'll get into medications. However, we just have a quick checklist that, with Rachel's permission, I'll reiterate. One is, what's your bedtime ritual as she went through? Are you getting yourself to wind down? Now, some people, by the way, have what's called non-24 circadian rhythm. They can't do that, and we tolerate that, and we treat our patient. But that's a different subject, which we can discuss later. For the average patient, if there is such a thing as average, which is no things as average. I tell my children not to be average. Don't be average. But let's say for the patient that's trying to do a normal circadian pattern, try to get to bed at 10 or 11, they may still be working. They may have to get up either with child care or get child care and getting off to work both. And they may find they have to get to bed a little bit earlier. A lot of people do better if they have quality sleep that's an extra hour or two. So there is a change in the dynamic of going to sleep, such that it takes some people, they don't rest well, and I think many of those who are listening today understand that it may take 9 or 11 hours, otherwise they don't have a good day, and we get that. The more we know about the particular structure of the sleep and the patterns of the sleep, the more that we can help you. And we're not adverse to working with sleep physicians by any means. But we have a lot of experience as well, and we're more than happy to refer if we think it's necessary. So just to reiterate one more time, if you can't go to sleep, and we'll get into that in a minute, then that's one issue. If you can't stay asleep and you're being awakened, and we'll get into some of the causes of that, that's another issue. The bottom line is we need to get quality, efficient sleep for you to refresh and rinse your brain. And that typically occurs in the first portion of the sleep cycle. And that's your delta wave sleep, or deep sleep.
And it might be worth touching on the different, types of sleep disorders now, Dr. Jemsek, before we get into some of the other questions, and I'll let you expand on this as well. But, like Dr. Jemsek was saying, we ask a lot of the same questions, like, are you having trouble falling into sleep, or are you having trouble staying asleep? but it's much more complex, than that. Trouble falling asleep, Dr. Jemsek will always tell his patients, is many times because the brain is in an excitatory state, right? And so the brain feels busy, it can't shut off. Patients will many times say, I feel tired, my body is tired, but my brain is awake, right? And we feel that that is linked with glutamate being too built up in the brain. And we'll talk in a minute about medications or supplements that can kind of help to reduce that or help calm that brain down. The other aspects of sleep that are affected or can be inhibitory are things like pain. So if patients have orthopedic issues or Lyme arthritis or whatever the case may be, pain can keep them from getting deep sleep or from even falling into sleep at all or staying asleep. Patients tell me all the time, well, I roll over and then I'm in an excruciating pain and then it takes me a while to fall back asleep. Getting up to go to the bathroom frequently. I always ask my patients, how many times are you getting up to pee at nighttime? While some patients say that's normal for them, it's still disruptive to their sleep depth and time when they're in that delta or REM sleep. Restlessness, so tossing and turning, we ask a lot about, as well as night sweats, which can be excitatory or linked with babesiosis or even the cortisol axis, which we'll talk about a little bit more. Having vivid dreams is another thing that can be disruptive, or night terrors. Dr. Jemsek can talk about the different parts of the brain that affects. So all of those components are important and types of sleep disorders that we have to work with.
Right. So thank you, Rachel. That was a nice summary. So our patients get a list of 8 to 10 questions asking, what are the primary factors affecting their quality of sleep, and then we make a disposition and a determination on what to prioritize. So getting into sleep is important. You don't want to toss and turn for 2 hours, and if you do, we need to know why. And then once you do get into sleep, we'd like you to stay there in a comfortable situation, hopefully with breathing issues either under evaluation or being addressed if they're present. And address restlessness, which can be most disruptive, because remember, the body is to be very quiet during part of the night. And if you're restless, again, that disturbs the delicate delta wave formation that's restorative for the brain, allows for the vascular changes so that the brain can detox. Pain management is a big issue. We don't use narcotics, but we are okay with certain muscle relaxants and certain topicals, especially if they're pain triggers, which there often are, especially in the head and neck, but also in the paraspinous area and other parts of the body for that matter. So we try to use the least habituating program, if at all possible. And then for deeper sleep, there's a handful of medications that we'll get into, and those who attend the clinic are familiar with most of those. There's a handful of medications that do help promote deep sleep, and Ambien and that group are not in that classification, unfortunately. But some people do take Ambien, and we tolerate that, but we'd rather have you on something that we think promotes delta sleep. I think I'll stop there. We have a lot more to discuss, but
yeah, I was about to say that that actually leads us really well into the next question that you guys sent in. You guys sent us some really good questions this time. Not that you don't always, but so a question one of you asked is it okay to take medications to fall asleep? What if I'd rather use marijuana-based products? What are your feelings about this? So, Dr. Jemsek touched on this already a little bit. We don't want to talk about specific medications, but we can talk about groups of meds and what their benefits might be. There are also a lot of herbal options that are really helpful. But in general, if it's going to aid in patients' ability to sleep, we're okay with patients taking medications, and obviously it's case by case. But Dr. Jemsek can talk about some of the more natural meds and also just groups of medications that might help.
Well, the market responds to market needs, and in our present society, more and more people have trouble with sleep or If you just look at the infomercials with beds going up and beds going down, and dad having his bed one way, mom the other way, and the temperature the same way, and it's just a testament to the fact that sleep is very important. But it also maybe reflects the fact that there may be more neuroendocrinologic illness in the society than there was in the past, or that's hard to say. But there certainly has been a surge, and there's parallel surges in exercise promotion, advertisements for special antioxidants that are promoted, and of course mental health concerns about what's going on in our society. So clearly, I'll just put it in very blunt terms. If our patient comes to us and we say, we have to stabilize your sleep to a satisfactory degree, you may or may not need to see a sleep physician, depending on whether you've seen one already. There are home devices that some of them are happy to have you use, which would be useful to us. We also have in our technology smartwatches, some of which may be helpful and some of which may be overpriced. I'm not the expert in that market, but I do know that there's been an exponential increase in that, so it can record. And I think the data from the better brands is relatively helpful for us to know, because we have a certain idea of how much time we want you and Del to sleep. But if we've eliminated restlessness and getting up at night to go to the bathroom, which is, by the way, is an endocrinologic condition called diabetes insipidus, which is relatively common, affecting a hormone in the posterior pituitary, damaged by, guess what, our friend Lyme borreliosis and his colleagues, and causing the patient to be up at night with large volumes of urine, which totally disrupts their sleep. It's not generally thought to be life-threatening, but it is life-disruptive. So that's one of the many things that we ask about, restlessness being another one that has to do with limbic irritability, inappropriate dampening of limbic signaling, so that we get jerking at night. Some people will lift their heads over their arm and chant at night because of limbic irritability, or sit straight up in bed. And we have medications that hopefully can help that. It's all about trying to get as normal a sleep pattern, or as acceptable a sleep pattern as we can, so that we can get on with treating you.
Yeah, and I agree 100%. I think a big thing that is important for our patients to know, and also just those of you watching, a lot of times Dr. Jemsek and I won't hesitate to, pause a patient's treatment protocol or delay initiating antibiotic therapy or herbal therapy if their sleep is still poor. And I think the take home that I had to learn kicking and screaming from Dr. Jemsek when I first started working here, because I don't have patients and wanted to just start patients right away on antibiotics, was that, if patients are not sleeping well, they will not see improvements in treatment, but also it makes it very difficult for us to see the different nuances and differences between antibiotics and their recovery periods. So this is a huge tool for us as practitioners. If the patient is sleeping well, it allows us to interpret their care and augment their care as needed. The other thing I wanted to touch on, asking in regards to medications, there are drug classes that tend to help more specifically with restlessness or nocturia or falling or staying asleep. But the other things that we wanted to, make sure that patients were aware of are the natural sleep aids. So there are a lot of natural supplements that can be helpful, including just something as simple as chamomile tea, which might just be part of your calming habits as you get ready to go to sleep. Melatonin is a very common one, as is deep sleep, 5-HTP, GABA. So a lot of these can be helpful and can potentially have their own side effects, but some patients prefer to start with those more natural routes before getting into prescriptive sleep medications, all of which is fine for us as long as you're sleeping and sleeping well. The next question that we got from you guys was, during stabilization phase, I have been sleeping a lot better. Therefore, my symptoms have eased or calmed down. Should I start treatment anyways, or just stick with the stabilization? So this is a great question. We get this a lot. So our aim at stabilizing patients before they start antibiotics is to feel better. So we want to, calm their pain, stabilize their gut, and get them sleeping well so that we know that they'll be able to put their best foot forward with responding to antibiotic therapy. When we are stabilizing them, we are getting them on supportive supplementation or prescriptions that get them into a better quality of sleep. And so many times that means that they will feel better during the day. That doesn't mean that they shouldn't still treat, because we know that the bacteria is still there. So at some point, the compensation that we are creating by helping with sleep or pain or otherwise will no longer be effective, and the infection will cause increased inflammation and decline. But we do think that stabilization allows for an immunologic reset, which will many times make patients feel better. The other component is in how we start treatment, which is slowly, and Dr. Jemsek will talk about that a little bit too.
Thank you, Rachel. It's very important to understand our patients. We're talking about sleep today, but our patients also have cognitive and mood disorders that are acquired. They've been displaced from their usual comfortable situation in life and the relation to those that they love and those with whom they work. There may be other factors going on, metabolic factors, because our patients are chronically inflamed. So a patient may say, well, I'm sleeping better, but I'm still tired. Well, you have to distinguish. Is this about sleep deprivation, or is this about being tired, or both? And I think that's important to distinguish. And of course, we do everything we can to identify organic reasons for deterioration in elemental life supports in terms of hormone loops, critical coenzymes, critical vitamins, critical mitochondrial support molecules, and so forth and so on, to stabilize their patient in terms of fatigue. However, that doesn't fix most patients, because they're still dealing with an ongoing oxidative stress, which means their body's chronically inflamed. And anybody who's watched this series knows that that's the crux here. And can you imagine trying to slowly bring that into shape and improve that without sleep? And the answer is no, because there's so much frustration cognitively, and your ability to process doesn't improve if you're sleep deprived. And I think at some point, we've talked about, I think our general goal is to try to use not habituating medications at the beginning. A lot of patients come to us on habituating medications, namely the benzodiazepines. Mm-hmm. We respect the benzodiazepines, but they're very, very helpful and sometimes necessary, but we often have a situation where we'll use benzo-sparing medications, such as CBD products, which are now available, such as some of the antihistamines, because histamines are activating neurotransmitters, as I said before, along with glutamate. For glutamate, we'll use theanine or taurine to help compete with the glutamine receptor sites, so there's not this ongoing excitation. Dopamine and serotonin have different subsets, and so they may have different activities. But our poor brains their threshold for being excited is lower. So if you have something going on, it's going to excite you, and then that leads you down a undesirable pathway in terms of poor quality of sleep, which just makes everything worse and is very hard to recover.
One question that you guys just asked us through the live stream, and then I want to ask Dr. Jemsek about the CBNs a little bit more. One of you had asked what the best magnesium for sleep was. There's lots of different types of magnesium out there, as you guys know. I personally like magnesium malate for my patients. that I see, you guys know that I push that a lot. The magnesium malate is gut neutral, so it doesn't affect, it doesn't have any of the stool softening capacities that like the magnesium citrate does. It's also helpful with, nerve and muscle discomfort, which can help ease patients into sleep. So I tend to use that one. I don't know if Dr. Jemsek, you use a different one.
I use a combination of that and 3 and 8, I think.
Yeah.
But magnesium is very, very important in terms of it does have a calming effect on, so if somebody has some fasciculations like involuntary nerve movements or even limbic jerks, that's a go-to. Now we may still use a neurotropic, a seizure med, to help with that, because if the patient is jerking throughout the evening, that's another disruptive feature for delta sleep, and we're trying to preserve delta sleep. Some of these smartwatches, and I'll let you do your own research. We're not in the business of selling, towels or slippers or smartwatches. So, but you can do your own research and make your own decision. There's plenty of information out there, and it's become quite competitive. So I think the prices are fairly set.
One thing that I wanted Dr. Jemsek to touch on a little bit more was the receptors for sleep in the brain as it pertains specifically to CBN, because we've gotten a lot more into that in regards to its benefits that our patients have seen. Do you mind talking about that a little bit more?
Well, in general, the whole field of the endocannabinoids is exploding into a $1 billion industry. There must be thousands of companies that make it. I'm sure many of them make a quality product, but the consumer is left often confused. So it leaves us confused too. Now, if a consumer says, okay, we found that something called so-and-so and it's wonderful, I don't discount that. I just want to make sure that it's being monitored and it's being reviewed and it's getting accreditation. We know the national companies do that, and I know the national companies are probably a little bit ahead in terms of extracting CBN, which is just a molecule or two difference from the broad spectrum of most of the molecules in the class. We have CBC, we have CBG, we have CBN, we have CBD broad spectrum. So I'm not an expert of each of the nuances of that. I know one's a little better for anxiety, but the idea of having a concentrated extraction of the cannabis molecule, which is about 2.6% of the molecule, is attractive, and I think it's shown some success. And the other thing, in talking with one of my esteemed colleagues, while the studies are yet to come out, he thinks that it has deep sleep promoting qualities. So I think that's a plus. So CBN, and the companies that everybody knows about that we might use would include that we feel safe about using. Now, that's not to say if you have a trusted local pharmacy and they can show that they've certified their product. I'm not saying don't use that. I'm just saying that the ones that I think that are in access with everybody and can ship interstate would be Charlotte's Web, Bluebird Botanicals, Lazarus, and New Leaf, NULEAF.
They are not a paid sponsor.
No.
But yeah, no, we've worked with those companies for quite a while. I myself have recommended Sun Soil to patients before, with their products being just really excellent. So yeah. Okay, I'm going to give you an easy question, Dr. Jemsek. Does having very vivid dreams mean that you are not getting into the deep sleep that you need?
The answer is yes. And sometimes those vivid dreams are enjoyable, and the patient doesn't seem to mind them, and the question is what to do about that. But sometimes they're intrusive and can be frightening because they are disturbing, and so those need to be addressed for sure. It's kind of like when I ask a patient if they're having hallucinations or out-of-body experiences, and they say yes. My next question would be, okay, does it freak you out? Because if they're not on an antipsychotic or atypical antipsychotic, that means I have to put them on one, and I'd rather not use more medicine, if possible. A lot of people will say, no, I just kind of enjoy them. I've come to be friends with my musical apparition and that sort of thing. But some people get freaked out. It's totally disruptive. This has to do with a brittle brain and sensitive areas in the brain, the lower brain, where the sleep centers are, seeing a surge of norepinephrine. So we have medications on the market. We have a couple that are really quite effective in blunting the attachment of norepinephrine to the synapses in the brain. Therefore, the activity is not carried out. And so this is different from the busy brain that we talked about. It's different from people who respond to histamine, and that helps them sleep. So it's a very interesting series of nuances. But the point is, we have to let the brain enter into deep sleep. And if we can do it with benign and what I think are very safe medications that we titrate carefully, then that's a win, and that lets us proceed with therapy.
And I would agree with that. I think from within my practice with the patients that I see, I tend to err on the side of not wanting patients to dream, mostly because even if it's a nice dream for them, I know that it's keeping them typically in that lighter level of sleep. So, I'm a little bit more lenient with vivid dreams or nightmares or whatever the case may be as patients get towards maintenance or when they're done with treatment. I tend to not want them dreaming as much, particularly if they're still waking up feeling unrefreshed. The next question we got was asking, why does everything hurt the next day if I go to bed late, even if I get 9 hours of sleep? So it's a great question. There's multiple answers to that. Number one, we go back to needing to have a regular bedtime and knowing that, for most people, having a circadian rhythm, that means going to bed, between 10 and 11 p.m. That's kind of a happier, sweet spot for a lot of people. The other component is, if patients have a lot of inflammation and orthopedic or Lyme arthritis type issues, that may cause them to have more pain in the morning if they've not moved around a lot. It builds up inflammation and then they just feel really achy, even if they've gotten that 9 hours. But getting to sleep at an appropriate bedtime at the same time as much as possible each night, is helpful. Anything to add to that?
No, it goes back to sleep hygiene and, whether the issues are with getting off to sleep or staying asleep or both. And if something's interrupting the sleep, then we have a list of 8 or 10 questions that hopefully will identify one or more interfering activities. One
of the questions you guys just wrote in, which I think is a good one, and Dr. Jemsek touched on it a little bit earlier in the conversation, was asking or stating essentially, when we do start antibiotics, after stabilization, how do we start those? And I just wanted to reiterate, because this was an important thing that Dr. Jemsek and I talked about before starting the Facebook Live stream today, is that stabilization is a hugely important aspect, and if we can get patients feeling better with just the stabilization, we get super excited. But then when we do start treatment, we start slowly. We start with antibiotics that are going to, slowly, peel away this infection and shouldn't cause patients to, crash or feel awful and need to be restabilized immediately. So that was a good question. One of you guys actually had just sent in.
If I could just add to that.
Yeah.
And if you do destabilize, then it's our job to restabilize you. So let's say sleep wasn't a big issue, but then you get started on your first month or two of very gentle induction therapy, and now you can't sleep. We need to know that. and we need to make adjustments for that to get your essential life function back into order.
You guys are sending in some excellent questions during this live, so just to be aware, I'm keeping track of all of these questions, and this is why Dr. Jemsek and I think are going to do a second live stream specifically about sleep. So if we don't get to some of these, we'll touch on them at the next live. So I wanted to get to this question for you, Dr. Jemsek, which is, how much sleep on average should I get during treatment? Is it more than 8 to 10 hours?
Well, I mean, I think there has to be tolerance involved, and that's why the very best situation for somebody who's morbidly affected by this illness, and there are millions of people out there that aren't seen by, we don't see everyone, of course, we don't treat everyone with IV, but that doesn't mean that you're not fundamentally impacted at a very bad level, and which threatens your career, threatens your family, threatens your relationship with your friends, church, etc. So we need to know that there's going to be support for you who may be a spouse in an existing home, or a child that has an adult child having to move back in, or even another relative that said, look, and this is part of our initial discussion, this is common, unfortunately. The poor brain is on fire. It's affected so many parts of our involuntary nervous system. And these are all essential life functions, and they need to be stabilized without us drugging the patient to numb them up. We don't do that. Patient feels altered status on a medication, that medication goes away. So, but every patient's an individual, but if you do need an extra 2 to 3 hours of sleep, I pray that you have a conducive environment in which to do that, because that's the nature of this illness for the next several months or even up to a year before things start to improve.
Yeah, so just to reiterate, we are pro naps. If you have the ability to take a nap during the day, if your system has gotten overloaded and you're just getting that crash point or exhaustion point, the sweet spot for the number of hours of sleep, again, as Dr. Jemsek said, is going to be different patient to patient. Some patients do fine with the 8 to 10 hours. Some patients need 18 hours of sleep, and they might still be tired during the day. So I think as a goal of getting, the 7 to 8 hours, as long as you're getting that delta sleep, and other phases of sleep, then that's kind of the ideal. Let's see. The next question is asking about, or stating that they can't fall asleep without lorazepam, and wondering if there are any tips for this. So lorazepam is a benzodiazepine class medication, also called Ativan. For those of you who are not familiar with that, many people think of it as just an anti-anxiety medication, but a lot of our patients use benzodiazepines for help in shutting the brain off and falling into sleep. So, what I would say in regards to this is, towards the end of treatment, a lot of patients are still on some of these stabilization medications, even though their body may or may not still need them. So sometimes the body will aid us in telling us that they don't need these medications anymore. We'll start seeing paradoxical responses to these meds, essentially because the system doesn't need them any longer. Sometimes because some of these medications are habit forming or habitual, it's tough to come off of them even if you're on the very lowest dose. So many times what Dr. Jemsek and myself will do is we will try to add supportive medications, such as antihistamines, over-the-counter supplements, natural sleep aids that help to get them into a deeper sleep that will allow us to slowly pull away those medications such as lorazepam if you're not wanting to still be on that. Would you agree?
Yeah, sure. So benzos pairing. So we have a job to do, and under supervised circumstances, we may have to incorporate benzodiazepines as part of a cocktail or as the cocktail because other medications haven't worked, and we have to get our patients sleeping. And so we do that. And we'll use medications like clonazepam or Ativan. Xanax is not our favorite. Half-life is too short. Perhaps the diazepam if there's a lot of myoclonus or muscle spasm, for example. Or sometimes a combination. A lot of our patients have seizures and are on benzodiazepines during the day for the seizures, along with their new best buddy, the cannabis family. So one of the things that we can do is put in either a broad spectrum CBD and a lower dose to titrate up, either a gel cap or a gummy or drops, or the CBN product that I discussed, which is primarily a gel cap, I think, but there's also TH8 and TH9 available at some places. However, the point is we try to create a cocktail which will still retain the benefit of getting patients into sleep. And I mentioned before, CBN may help with the deep sleep as well. So that might be a positive, whereas the benzodiazepines typically do not do that. They do not promote deep sleep, nor do some of the other off-label medications. And so we're not thrilled about using them, but we understand the necessity, and we're always optimistic. Look, if we can get the brain better, which we can in most people, while it's not the easiest thing to do, you should be able to titrate and withdraw from this medication over time.
All right. So one of the things that I wanted you to touch on, Dr. Jemsek, it was a question we got previously, and one of you just brought it up in the conversation for Facebook, is talking about an inverted sleep access. So a lot of you will be like, Rach, I'm wide awake, I can be super efficient during the nighttime, and then I want to sleep all day. What does that mean? And we know part of that has to do with, the cortisol access, but I wondered if you would touch on that a little bit more.
Yeah, I was just thinking about that. Thank you, reader, follower, for bringing that up, because that's an important point. People get so confused. Okay, I'd like to go to sleep at 10 o'clock or 9 o'clock. I try to go to sleep sometimes at 9 o'clock or 10 o'clock. And but that's when my brain comes awake, and that's when I want to do things, and that's when I want to be busy, and that's when I want to do paperwork or go on the computer or clean the house or do the laundry. And what time do you go to bed? Well, sometimes you go to bed at 1, sometimes 4, sometimes 5, and then of course that patient's sleeping into the next morning or next afternoon. Okay, how do you live with someone like that? So this is something we need to work out between families at the very beginning. This is called an inverted adrenal axis. So instead of the cortisol, which our body's anti-inflammatory and stimulatory hormone at the same time, is highest in the morning. It gets us up ready for the day. And then it drifts down as the day goes on, and then it's down at its lowest level at late evening. And if it's the opposite, where it's lowest in the morning, you have nothing going on for you in the morning, you can't get going, your blood pressure has trouble mounting, you can't get your autonomic nervous system engaged, and then it may gradually improve. You may be napping, you may be doing a variety of things, but not doing much productive until about 9 o'clock at night or 10 o'clock at night. You need to say, the lights come on, I'm ready, let's watch a TV show, honey. Let's watch our favorite soap or movie. And that has to be recognized, because typically what you do, you get a blood value in the morning. Even if you've heard this history, you get a blood value in the morning that's way low and saying, oh my God, this patient has adrenal insufficiency. And it's probably secondary. The adrenal's not working. But then if you're not careful, it's what happens to us in the past years, not recently, is that we give a little bit of hydrocortisone in the morning, and that has a very disruptive effect on the patient's day. And they do not like it at all, because it's like giving somebody hydrocortisone at night, which is a stimulant in a sense, just to right at bedtime, and they can't sleep. I'm sure you've all of this is in the extreme. You've heard of steroid psychosis, when a patient may get a high dose of steroid for something or other. And so there is a definite stimulant effect. So anyway, we can't do much about this. We just say, let's treat your illness and let's see this big, cruise ship turn around in the ocean and see if we can't get you back to a normal diurnal rhythm slowly. And I would say in 40 or 50% of cases we can do that. I would say more than that. It's just a painfully long journey, unfortunately. But as long as everybody's on board and allows this person to sleep in the day and reverse their day and night, it's one of the things we try not to do much about because we know we won't be successful.
And that goes back to identifying the different things or disorders of sleep, whether it's pain or restlessness or whatever. If you have an inverted, cortisol axis, that's a disorder that contributes to poor sleep. So getting adequate testing to identify that inverted sleep, as well as ruling out to make sure that it's not actually these other causes, is super important. And like Dr. Jemsek said, many times when we identify that inverted sleep axis, you kind of got to roll with it because it's really slow to get it back to more normal. But we see as patients are treated and see improvement, they can slowly edge back to a normal sleep schedule. But again, it takes a long time. One question, and we're running low on time, but I wanted to get to this one too. A person had asked that they just got diagnosed with Lyme and have not experienced any sleep disorders yet. Should they expect that symptom soon? And I'll let Dr. Jemsek weigh in as well, but I think we have some patients that never have issues with sleep their entire treatment. I would call them unicorns.
Not too many.
Because most of our patients at some point will have disrupted sleep for one reason or the other. So if you don't have disrupted sleep and you are diagnosed with Lyme and you never end up getting disrupted sleep through treatment, then you are a blessed one. But yeah, I would think that at some point during treatment or your illness, sleep will be affected, particularly if it becomes more neurologic in nature.
Yeah, because the hypothalamic pituitary area is heavily hit. It's a small but critical area in the upper shelf of the bottom of the brain, the limbic system. It's extraordinarily important in regulating appetite, all the hormones, sleep, and so many other things. So it eventually it's at risk. Let's put it that way. But the hope would be that your symptoms would come on, gradually be identified, and we'd have priority approaches for rectifying that with the most gentle approach possible is what we typically do. But to think that you'll never go without sleep or never have a sleep issue is rather unlikely, quite honestly. But our job is to navigate you through this treatment, keeping you within certain boundaries so that you never feel like you're out of control or this is not manageable. And that's part of what we do. So we track all these parameters and prioritize what we do as we go through our treatment programs and get you better.
And then one final question, because it's everybody's favorite topic, is people have been asking about how parasites affect sleep. Dr. Jemsek's going to kill me for asking this one. But how parasites affect sleep, I know people sometimes feel like the moon cycles affect their sleep, and they bring this up a lot. And so people were asking, what our thought process was behind the science of or the cause of disrupted sleep from parasites. If you can touch on that briefly.
Well, Alan Nicholson is the guru for parasites in the brain. He's discovered them, and I'm sure they play a role. I'm not sure how they fit into our anti-infective program. Now, we do have all types of other diseases associated with parasitic disease with Lyme borreliosis complex. So I'm not diminishing parasites. They're very important in our spectrum, our approach and role. But as far as sleep per se, I am not as familiar there. I would make an analogy to Morgellons, where people have fibers,
Yeah.
which are presumably hybridized portions of keratin and spirochetal antigens. And some have them and some don't. And our experience there is that we consider them a morphed hybrid of some sort of parasitic entity. And our success with treatment long term is that shows that we can reduce those just by treating the underlying process. I will say one other thing, because you mentioned the moon, the full moon. That's real, by the way. So most of you probably know that dysautonomia or dysfunction of the autonomic nervous system, parasympathetic and sympathetic, is part and parcel of this illness. And this is when you can't be cold, you can't be hot, and one body's hot and one body's cold. You're having chill bumps, and you're having flushing, you're having vascular changes and prominent blood vessels, you're having gut motility, you can't tolerate motion. Well, one thing can happen if your brain is that sensitive is that 1 or 2 millimeters of mercury with full moon will affect you. And I am a believer. I mean, I've heard it too many times, and it makes sense. That's how sensitive our patients are, which is a commentary on just, how badly the neurologic systems have been damaged. But it's real, and yeah, so that's real. Now the worms, I don't know.
Yeah, my thought process always with the parasite component was just, and similar to Morgellons, I think, a lot of that can become more active when we're sleeping, or we're just more aware of it when we're sleeping, similar to the Morgellons sensitivity. But yeah, so thank you so much for everyone participating today. We love getting your questions and being able to talk through some of these more complex issues within the Lyme community. We're hopeful to be back with you in a month or so to do a part 2 of the sleep discussion. So definitely send your questions our way so we can make sure we can answer as much as possible. Thanks so much.
It's a pleasure to be back online with everyone. So sorry we were gone. It was let's say I was on sabbatical. How about that?
Bye, everybody.
Bye bye.